Good evening, aspirants. Today's
Good evening.
topic is case-based discussion on pregnancy with hepatic disease, and it will be taken by Dr. Sharmili Sinha. She is the speaker over here. She's a senior consultant critical care medicine, Apollo Hospital, Bhubaneswar, and the organizers are Dr. Akhilesh Tandekar, Dr. Gunadhar Padi, and Dr. Asif Iqbal. And the moderator is Dr. P.L. Gautam sir. He's the professor and head critical care medicine, Dayanand Medical College and Hospital, Ludhiana, Punjab. So, ma'am, you can begin the class.
Thank you, Susmita, for the introductions, and good evening to all the participants, and welcome Dr. Gautam, and Dr. Aarti Mona is also with us. She is the third year DM critical care trainee from Dayanand Medical College, Ludhiana, and working currently with Dr. Gautam's team. So, as we have heard, the title, it is about pregnancy with hepatic disease. So, we'll start with the topic. A brief overview I'll give, followed by two interesting case discussions, which we'll be covering through question answer session. And you feel free to type in any queries, any questions that we'll be taking up during the discussion as well. So topic is pregnancy with hepatic disease, as we understand. And so that occurs, we know that pregnancy is a physiological state, and there occurs numerous physiological changes in all systems in the body, starting from head to toe, be it the brain, be it the circulation, cardiovascular system, respiratory system, gastrointestinal system, including the liver changes. Also in the renal system, we have cutaneous changes as well, and more importantly, also hematological system. So there are numerous changes which are happening during all three trimesters of pregnancy in all these systems. And it's a very common question also asked during the various exams, either in the written or in the MCQ or A or Q type questions, or also during the OSCE types questions, or also if you're appearing for a bedside clinical case discussions. This is a favorite question of all examiners. So we should be thorough with all these physiological changes which is happening in pregnancy. Now coming to the topic specific for today, physiological changes happening in liver in a patient with pregnancy. So normally we see there are mild increases in the alkaline phosphatase levels, which could be 3 to 4-fold because of the placental productions. Then what? Clotting factors, you see the fire, or most of the factors like factor 1, 2, 5, 7, 8, 10, and 12, there are also mild increases. Ceruloplasmin level also increases, which is a protein synthesized by liver, as well as the transferrin level. Now, there are decreases in the gallbladder contractility. So, more of this cholestasis are probable to occur, though not occur in all cases, but the overall gallbladder contractility decreases due to probably the hormonal effects. And similarly, because there is a mild increase in the total blood volume, albumin and total protein levels are also mildly reduced. It may be due to the hemodilution problems. And antithrombin 3 and protein S levels are also slightly reduced. So it may be slightly, may be responsible for slight hypercoagulable state, which is usually attributed to pregnancy. However, no changes or gross changes we see in the transaminase levels like AST, ALT, GTT levels, bilirubin levels, and prothrombin time. And deranged liver functions, if you look at the literature, affects up to 1 to 3% of all pregnancy. And of this, actually, a very small percentage go into develop severe disorders of the hepatic dysfunctions, which usually proves fatal unless gets timely attention and you are providing multidisciplinary advanced care in a tertiary center. Now, let's look at the overall causes of jaundice in a patient who could be pregnancy, who could be pregnant. Like usually the causes includes both the normal causes, which could be pre-existing, and also some causes which are unique to pregnancy. So there are high possibility, as you see in woman lady, as now the conception age is advancing up to in the probably early 30s or sometimes even late 30s. So, and that could be pre-existing lifestyle disorders like diabetes, hypertension, also alcohol consumptions and other habit formations, habit forming behaviors are also increasingly we see in the modern lifestyle. So these also contribute to lifestyle diseases and coexisting diseases. So that could be pre-existing cirrhosis and portal hypertensions. Due to increase or better methodology and advancement in the tools and technology, patients with chronic liver disease also, like especially the women, are also now able to conceive, and they are the ones who actually might be having pre-existing liver disease. Autoimmune hepatitis, if it is even indolent, it might actually get aggravated during pregnancy. Primary biliary cirrhosis, sclerosing cholangitis, these are rare though in obstetric women. And other congenital diseases like Wilson's, chronic viral hepatitis B and C is very much possible in Indian populations and also in various LM, low and middle income countries, and chronic liver diseases of any other etiologies. Now, some diseases coincident with pregnancy, it could be Buercher syndrome. Again, viral hepatitis, mostly it is viral hepatitis A, which is more commonly associated with pregnancy. Other viral hepatitis like herpes simplex virus A, B, C, rare though, and then you have cytomegalovirus, alcohol and pregnancy, as I was mentioning about the increased lifestyle changes in the modern life. Also, it can be contributing to deranged liver functions. Gallstone diseases could be pre-existing. However, there is around 5 or 6 conditions which are unique to pregnancy, like acute fatty liver of pregnancy, preeclampsia, mostly the severe preeclampsia category, eclampsia, and then the HELP syndrome, and we have intrahepatic cholestasis of pregnancy. Other one is the hyperemesis gravidarum. So we'll actually address more of these 6 conditions which are unique to pregnancy. I believe we can see the slide. Right. So in acute fatty liver of pregnancy, you see, usually it happens in the third trimester of pregnancy, and the symptoms are again non-specific nausea, vomiting, and patient actually rapidly progresses to fulminant hepatic failure. ALT, AST, which are generally common within normal limits in a patient with pregnancy, it is not physiological changes, can go beyond 300. Bilirubin rises, PT rises, and they frankly and land up in DIC. And definitive management is the delivery of this patient, but these patients, remember, are very highly sick, a rapid progression of all liver function. And because of this deranged liver coagulation problem, also delivery becomes a challenge. And of course, maternal mortality is high. Compared to that, fetal mortality is even higher, up to the tune of 45%. And but it is usually happens in patients who are primiparous. Multi-fetal gestation is there, but you look at the rate of occurrence, usually very low, less than 0.1% of these cases. Now comes this eclampsia and preeclampsia. Preeclampsia, usually we know the mild and the severe categories. Usually severe preeclampsia is associated with some degree of liver dysfunctions. However, some of them might again go on to develop severe dysfunctions of the liver, and also acute liver failure can set in. These patients invariably have associated of high blood pressure. That could be there is existent or associated presence of edema. Seizures are present when severe preeclampsia progresses to eclampsia, and other multi-organ functions, dysfunctions like renal failure of various degrees. Again, pulmonary edema also sets in these patients. If you are looking at the blood investigations, it is associated with high uric acid levels, and ALT is less than 500. Proteinuria is a very important accompanying feature of eclampsia and preeclampsia. Actually, in fact, in the screening of ladies in the ANC during the antenatal checkup, all patients during their ANC should have a urine dipstick to check for proteinuria. Many a times it is seen that even before a high recording of blood pressure, the urine dipstick could test positive for protein, and hence it provides an alert for the obstetrician that this patient might be in the just in the stage prior to developing frank preeclampsia, and they should be under close scanner. Again, they are also prone to develop DIC. Usually it happens in the second half, in the second and third trimester beyond 20 weeks, and that's the definition. All candidates appearing for the exam must be very well versed with the definitions of preeclampsia, eclampsia, the timelines, because this is the one of the next to postpartum or peripartum hemorrhage. This is the second most common cause of morbidity and mortality across the world. So you must be well versed with their definitions. Now, these are the common treatments. I'm not going to the details. Maternal mortality remains high. Premature delivery and fetal death remains also high, depending on the setup and the time of presentations. HELP syndrome, as it is in the name, there is hemolysis, elevated liver enzymes, and low platelets. Usually, it is accompanied by low abdominal pain. There could be seizures. As I said, it is usually 80% of these cases, usually it is associated with a history of either severe preeclampsia or eclampsia. Again, there are multi-organ failure and catastrophic complications like liver hematoma or rupture also can happen in these patients. When you talk about low platelet, it is usually less than 1 lakh, and there are features of hemolysis, microangiopathic hemolytic anemia is there, and you get all the features of this deranged liver enzymes and DIC. Beyond 22 weeks, as we see in this eclampsia and preeclampsia, and prompt delivery again is the answer. One of this devastating complication is the hepatic rupture, and that's why as soon as these patients are diagnosed, one should, after stabilizing the mother, should straightway go for delivery of the fetus, regardless of the fetal maturity. Now, this is hyperemesis gravidarum. Usually, it is intractable nausea, vomiting, and pruritus, etc. happens. First trimester, it is seen and resolves usually after 20 weeks. But this is one of the, again, very one once it sets in, many cases it leads to hospitalization, and all it needs is to adequate hydration, symptom control, give them some vitamins. It is usually benign for the mother and the child, but the morbidity is very high, so they need to be counseled. The other one is the intrahepatic cholestasis. Again, here at the top one, and it is usually again there is a lot of pruritus due to accumulation of the bile acids, and the definitive management is delivery of these patients. And because of this bile acids levels are high, etc., they can affect the fetus, and it can lead to fetal distress. Again, delivery is the answer. So all these cases, you see, you need once it is diagnosed, and if it is causing going to affect multi-organ functions, delivery is the definitive management. So this is a kind of summary of what we discussed in the last busy slide. I would like to also emphasize upon sepsis with multi-organ dysfunction, because many of patients who usually are presenting also have a very close differential diagnosis of sepsis and septic shock with multi-organ failure. Patients who present late, either they have been treated at the community district hospital level or smaller centers and are referred after 3 to 5 days, it becomes very difficult to differentiate between the primary cause, which is unique to pregnancy, along with superimposed infections, which might have caused sepsis, septic shock, and now patient is presenting with MODS. So sepsis should always remain as a differential diagnosis in such cases, unless otherwise proven. Viral hepatitis cases are actually, incidences are higher than reported, especially in our country, because to my understanding, in my experience of around 20 years, I see not all the centers are actually sending samples to test for viral hepatitis. So if you are excluding other possible causes, you should have a high degree of suspicion for viral causes of hepatitis. And again, not to forget the tropical fevers. We are actually almost, very highly prevalent, see high prevalence of dengue, scrub typhus, and though malaria is on the decline, but still, probably in the remote areas, still malaria and the travel areas, malaria is there, but dengue and scrub typhus is also very common. So if you're excluding other possible causes, keep in mind and eyes open for these tropical fevers as well. And never forget to take a history of drugs for that cases. So this is actually a busy slide. I have taken it for up to date. These are the five conditions actually which are unique to pregnancy and cause severe derangement of liver functions, asking for either ICU admission for patients with jaundice or pregnant patients with jaundice. And of this, you see the more severe organ dysfunction with fast worsening occurs in patients with acute liver failure, acute fatty liver of pregnancy, and patients with HELLP syndrome, which is usually associated with severe preeclampsia and eclampsia. So now we'll start with the case scenario. Dr. Dr. Aarti will be with us, and Dr. Gautam, I'd request that we take her through this case scenario together. So I'll read the case. It's a 22-year-old primigravida who had twin pregnancy. Now she was having irregular antenatal checkup. According to the history available, they say that her blood pressure was normal during her visits, whatsoever she had. No known hematological disease. Now, yellowish sclera was noted actually a couple of days ago. And then she delivered, this was actually in retrospect. They did not notice this before. When we investigated the history, they said that probably before delivery, she had mild yellowish discoloration of her sclera. And then she delivered twin baby by LACS on 27th of February. It was an old case in 2017 outside our hospital. But post-operatively, she developed po- postpartum hemorrhage. It was managed with blood transfusion and tamponade was provided in the uterus. And on arrival, actually, she was tachypneic, hypotensive, and there was yellowish sclera. Blood pressure was on the lower side and she was tachycardic. Now, would you like to tell us, Dr. Arti, like what are your differential diagnoses at this stage?
Good evening, everyone. Uh, since this patient was in the
Can
third,
you open up your video also? Becomes
Yes, you're not visible actually. Yeah.
Okay, you can go ahead.
since this patient presented in the third trimester of the pregnancy, and baby is already delivered, the differential diagnosis at this stage, first we can think of HELP, then
Okay.
then sepsis, because the BP is low, 88/60. Then purpural sepsis can the other cause. Then viral hepatitis can be the other differential diagnosis. In the viral hepatitis, the most common viral hepatitis in the pregnancy, they are viral hepatitis A and E. Then tropical fever can be one of the differential.
Okay. So you think it could be HELP syndrome? Although we have not provided you the lab parameters, never mind. But it could be HELP syndrome. But as per the history that was available at the outset on the presentation, that her blood pressure was normal. And during her antenatal checkups. So would you like to revise or would you like to, I mean, it's fine. I mean, there's nothing is perfect or, can't pinpoint. You need to have a list of differential diagnosis. I agree. Right. Anything else? We'd request others to please mute for the sake of discussion. Yeah.
In other causes can be acute fatty liver of pregnancy, and there can be autoimmune hepatitis can be the
Okay.
cause.
So,
Right.
Then
So how do you,
yeah.
yes,
Metabolic causes can be there, like Wilson disease,
so exclusively
hemochromatosis.
RP, if I would say, what are the odd things in this slide presentation? Like background, what is there, and what is the current scene? If you can correlate with that and put the things in again in order.
Sir, patient, there is a history of jaundice before pregnancy.
On the card differentials.
Yes, sir. Sorry.
If you take the background, like patient's BP was normal and no hematological disease as such, but there is a yellowish sclera noted a couple of, although retrospective, but patient had a PPH, received transfusions also, received tamponade also, and currently patient is tachypneic and hypotension and zero. Okay, so if what is the background and what is the current, looking at that, if you have to put the differential in order wise, which is the likely and which is kind of like in hepatic and non-hepatic, putting like that, or the way Dr. Sharmili has told that there is liver diseases which are just coexistent and maybe unique to pregnancy. If you put three different pools of differentials, then how will you like to have it? So that we can proceed then one by one, differential ruling out or confirming or ruling out with the investigation, because ultimately it is the management and the investigation. If you have the differentials, we want to have the investigation to rule out, to confirm. So how will you put like high on the card, low on the card in differentials?
Sir, in the since there is history of jaundice and there was PPH managed with a blood transfusion and tamponade, so according to me, HELP syndrome is the first differential.
Okay.
In the hepatic causes pertaining to pregnancy.
Okay.
And sepsis is the another, because patient is hypotensive, tachypneic, And patient may be having some pulmonary disease or community acquired pneumonia before LSCS. So that can be
I
cause
think,
of
yeah,
sepsis.
you don't go towards pulmonary community acquired
Yeah.
pneumonia because we have
Okay.
not mentioned anything about respiratory symptoms. We have said, or probably you're looking, you could actually ask us
As
if this
part of
patient has
cardiopathy, you can still consider
Yes.
low BP and tachycardia, but not very odd things. So anything is possible, but keep the differentials which are nearby only, not rare. So what are the investigation you will like to have if you have this such picture? What are the investigation to prove it, and what should be the then management? Because already patient is hypertension. The first thing is the stabilization. How would you like to stabilize this patient, keeping in mind a pregnancy post partum? And then what are the investigations simultaneously you will order for this patient so that we can narrow down the differentials also?
Sir, in the management part, first of all, we'll start with the airway management. We'll start with the provide the oxygen to the patient, and we'll order the blood gas analysis. We'll check the vitals. We'll check the PF ratio. Before that we'll admit the patient to the ICU, and in the ICU we have ultrasound available, so we can do the point of care ultrasonography, and we can check the fluid status of the patient by measuring the IVC collapsibility index, and rule out the pulmonary edema by doing the lung ultrasound, and also check the cardiac status of the patient. And further, if the patient is not maintaining saturation or patient is tachypneic in pulmonary edema, we provide the positive pressure ventilation support in the form of NIV. And if the patient is not maintaining on NIV, or if the patient is in altered sensorium, we'll go with the ventilation, mechanical ventilation. We'll put the patient on mechanical ventilation. We'll intubate and put the patient on mechanical ventilation. Then circulation. Since the patient is hypotensive, we'll check. If the patient is hypovolemic, we'll give the fluids, and after that we'll start with the vasopressor support, and we'll also put the arterial line for invasive beat-to-beat monitoring, and thereafter we'll order the investigations. We'll
Do you want
order the
any
CT.
more information from the record, like patient uh, this having PPH, tamponade is there? Any more information regarding which can be related to the management also, that where he has been given transfusions, you can want to have more information regarding that also?
Number of transfusions.
Yes, number of transfusions.
Number of blood transfusion, because patient
What
can
sort of
develop trolley.
yes, what sort of fluid? How much fluid has? How much was the amount of PPH requiring transfusions? Number of transfusions and other products also.
So, what investigations would you like to send, Aarti?
We'll start with CBC with PBF.
What is
Then
that?
peripheral blood film, complete
Okay.
blood count with peripheral blood film.
Mhm.
We'll send RFT, liver function test, coagulation profile, PT-INR. Then we can go with ultrasound abdomen to rule out any retained products of pregnancy, which could be a source of sepsis. Then, since the patient is hypotensive, likely in sepsis, so we'll send blood culture and urine culture, PCT, and
What is PCT?
procalcitonin.
So one tip for all examinees is avoid short terms while going through the exam. Tell the full thing, not RFT, say renal function test, because not everywhere renal function test include everything. I have seen places which includes only urea creatinine. So say that I would ask for sodium potassium urocreatinine or renal function test which includes ABC, like that, and also procalcitonin if you think you're thinking of it, right? So you said that, and what other investigations? These are the blood tests you'll send. Did you mention about a blood gas?
No, a blood gas will initially I said in the airway, during airway. Then also to rule out the viral hepatitis, viral markers will send.
Right,
Yes.
because she had been operated outside, she has received multiple transfusions. And as Dr. Gautam was asking, actually would like to elicit like what kind of transfusions, if it is only packed cells or transplant or platelets or plasmas, etc. she has received, that will be also helpful because just sending the investigations. And would you like to get an imaging done? You said about ultrasound, right? You
Yes.
look for this B lines, etc. But one chest X-ray, would you like to obtain?
Yes. Chest X-ray
Yes,
also.
just X-ray it will be useful as well, right? And what you said that if the patient is hypovolemic, what do you think from these presentations with the history now this thing with there is hypotension, tachycardia? There are limitations of I'm not going to go into the details of focus at this point of time because you talked about IVC collapsibility index. He is spontaneously breathing patient, right? And she has probably definitely a protruded abdomen with uterus probably has not retracted to the complete pre-pregnant state. It is still be little elevated, right? So I think there are several, and she has an LSCS done. There'll be bandages on her tummy. So I think there'll be several limitations of focus in this state to start with, right away when the patient comes to the emergency and to the ICU. So what about the fluid challenge? Do you like to give or you would like to wait, do the focus and then only think of fluid?
We can give some fluid challenge in these
Yes.
patients.
Because
500.
this patient has some history of PPH, even though she has been given transfusion, it has been a peripheral smaller center. She is tachypneic, she is hypotensive, and you'd of course look at the blood gas to see the extent of acidosis or lactate, etc., which I have not provided here. You could have asked for that, and her blood pressure is low. So, under more probability, most of the common probability is that she is hypovolemic to some extent. We do not know the extent, at least some extent. There is definitely a component of hypovolemia. So, you can give a guarded, graded fluid challenge of say maybe 10 ml per kg, 300 up to you can give in small aliquots, what we call, right? And see the response for that matter. You'll provide oxygen. You have sending all these investigations, right? And in the ultrasound, what would you like to see actually when you're doing?
First of all, retained products of pregnancy.
Mm-hmm.
Then the liver,
Right.
architect of the liver, whether it is because in acute fatty liver of pregnancy, the liver
Mm-hmm.
is bright in color. Then rule out uh, gallstones in the biliary tract.
Right. Okay. So would you do anything else apart from this, all these things? It's a, clinical management part. Anything else in terms of communication? Who else would be required to care for this patient apart from you? Would you like?
Obstetrician.
Yes, it is very
Obstetrician.
important to call for the obstetricians as well because these patients usually require a multidisciplinary team care, isn't it? So you have to alert the obstetrician team on call as soon as possible, and also you have to talk to this neonatologist or the pediatrician team of your hospital because the babies have been delivered outside. They might have some many times if they're coming from far, they also bring the baby. We do not know what is the status of this thing, so they also neonatologists have to be informed for that matter. So now you have given food, you have given oxygen, patient is little stable. So
two differentials, I'm just interrupting, has been put on the chat
please.
also. One is hemolysis post-transfusion. Yes, that's why we consider the blood and this thing always high on the card. But hemolytic reactions are not that common unless until it's a mismatch, but it can happen also, especially if the blood group is A, where A1, A2 is sometimes, despite having patients screening, blood grouping matching, sometimes this thing can happen. Second thing is put ischemic hepatitis. Yes, ischemic hepatitis can happen in any patient who goes into hypotension. But because the patient has a previous yellow secreta, so we should always keep the possibilities of having liver disease related to pregnancy or not related to pregnancy in this patient or coexistent. That's very important. Rather than intrapartum having the problems is unlikely, although they can compound the picture. But another thing is most of the investigations are very difficult to AFLP, whether it's a acute fatty liver pregnancy or it's a HELP syndrome or it's any other microangiopathies which happens in these patients. very much overlapping, whether it's TTP or hemolymph syndrome. All these are sometimes really very difficult to differentiate. So proceed, Dr. Sharmili, next. What is
Yeah.
the
So now the blood, blood reports come back. There is severe derangement of the liver functions. Patient is in respiratory failure with hypoxia. There is severe acidosis, and there is acute kidney injury as well. And now there is a ultrasound has been done as you wanted, a large uterus with some artifacts, and there is moderate ascites, but there is no POC, product of conceptions. Usually remember as a rule in cesarean section, actually it is unlikely that any POC remains because it is open, the cavity is open. They usually extract everything, but as opposed to this vaginal deliveries, the chances of POC, written products of conception, is usually higher because the contraction may be inadequate. Sometimes there is atony is there, but in usually in CS everything is removed, but there is moderate ascites is there, and SOFA score is around 8 for that matter. So now these are the list of investigations you see. You can go through, Dr. Aarti. So this is on presentation. Hemoglobin is 11 and TLC is 35,000. Platelet count is 1.25 lakhs. Uric acid is 11.2. And D-dimer is high, right? So have a thought and if you would like to revise your diagnosis and
TLC is on the higher side. There is
Mhm.
35,000. So platelet is low and HP is 11. Sepsis.
Sepsis is a high possibility, of course. Yes, yes. But what about this? Is uric acid is also on the normal?
Is also high,
higher?
so help is can be the other possibility.
But help, what is the platelet count? Platelet count is 1,25,000. So platelet, we call it low platelet less than 1 lakh. So it is unlikely. Help to nahi ho sakta, right? According to the definition. But sepsis, remember, also can be associated as part of multi-organ dysfunction. That could be coexistent jaundice. And also that could be coagulopathy, which will also account for this kind of D-dimer. But uric acid is something, it is not an acute phase reactant. Usually if it has risen before, then only you find such high. That's quite high, isn't it, uric acid? So we'll go to the next set of investigations. I'll show you the thing. This is hematology, and I'll show you the other one. What happened to this? Yeah, this is one. Now this is the LFTs. Bilirubin is 12.2, direct and indirect, right? AST, ALT, creatinine is high. I said that she had acute renal impairment, and she also, the TLC had already shown. This is the same one that you seen before, right? So now right? So which, tell me, the first diagnosis, of course, comes as sepsis with multi-organ failure. And rightly so in our subcontinent, especially when they're handled in the periphery and shifted to higher centers. So which antibiotics would you like to give, Dr. Aarti?
We'll start with the broad spectrum antibiotic. Since the patient is in sepsis with multi-organ dysfunction, we'll start with the piperacillin tazobactam plus we'll cover for anaerobic cover also we'll give in the form of injection matrogel. And since the patient is in shock, so we will go with the staphylococcus gram-positive coverage also in the form of injection ticoplanin.
So what is the coverage of piperacillin tazobactam? What organism are you aiming to cover when you choose an antibiotics, in this case, puerperal sepsis?
Piperacillin tazobactam is a broad spectrum antibiotic.
No, I am asking what organisms are you trying to cover?
Gram negative. Main we are covering the gram negative organisms.
Okay, so what are the spectrum of piperacillin tazobactam? What all organisms does it cover? Does it cover only gram negatives or anything else, or no?
Ma'am, it covers all the organisms, but the MRSA is not covered by.
All the organisms means what? Which ones? Gram positive,
gram negative organisms and robes, but not MRSA organisms are not covered.
What about gram-positive coverage of piperacillin tazobactam?
It has a gram-positive coverage
It
also.
does cover. It does cover also the gram-positive organisms, and also it has got to some extent coverage for the anaerobics also, right? Those the uncommon ones. Also, it covers the anaerobic organisms. But MRSA, as you said, it may not cover. But what is the incidence of the likelihood of MRSA puerperal sepsis in our country compared to the common organisms for this lady? She was in a village in a peripheral center. She has not received any prior antibiotics. She does not have comorbid conditions. She has come for a CS. There is an there's a PPH, some tamponade, and now she is here. So, what is the chances of she is getting MRSA from the community? You believe?
Chances of MRSA cover is less,
Very less actually.
very
Because if you
less.
look at all the risk factors for MRSA, there is a long list of those. She does not fit into those criteria. So piperacillin tazobactam, by all means, by definition, is a quite a broad spectrum antibiotics and good enough, right? And you can actually add a metrogyl, but it is probably not required because piperacillin tazobactam also has got adequate anaerobic coverage. But to my understanding and experience, many surgeons actually prefer metrogyl as a because it has one antibiotic which has not shown resistance over decades, I think. So it also would be fair to give metrogyl in such cases. Doesn't matter, right? And what dose would you like to give to her?
4.5 gram 8 hourly.
IV 8 hourly. What about creatinine of 3.16?
Now we'll start with the 4.5 gram loading dose, followed by the maintenance dose as per the creatinine clearance.
So this is the creatinine 3.16. So now what do you,
Modify the
will
dose.
you?
Modify the dose as per the creatinine clearance.
Now, how are you going to, what is the cause of raised creatinine in this case? Is it acute or chronic or acute on chronic? 22-year-old lady from community?
It's acute.
Acute. So do you go
Acute.
for creatinine clearance in acute AKI? That creatinine formula, the Cockroach-Garoff formula that we normally talk about, only applies to stable creatinine clearance. It does not apply to patients with AKI because it's a progressive stage. So it would make, and what is for to understand that, you need to know what is the cause of renal impairment in our case. What do you think?
Pre-renal cause.
Pre-renal cause would be,
Pre-renal.
yes, on hypertension and hypovolemia of long standing may be there. And what else? Because you see the trend, it has normalized fast within say almost 2 weeks, right? So, and sepsis, there is a high TH3 sepsis is there, isn't it? It is also there, so that is a thing. And if any other concomitant pregnancy specific causes there, which we do not know. This all could be contributing to this pregnancy related acute kidney injury. There's a term called PRACI. All of you should know about it because this is a now distinct entity. It is often discussed in isolation. It's in a full topic itself. There are conference or session topics on PRACI itself. So you should know it's a pregnancy related acute kidney injury, and you should give the full dose of antibiotics at least for 48 to 72 hours. Because if you think sepsis is the cause of this degree of AKI, actually then you have to treat sepsis in the full dose. And always, whenever you're talking about this carbapenems and this penicillin and carbapenem, a cephalosporin group of antibiotics, it would look smart of you if you say that you can give it as an infusion, right? Over 3 hours, because we have a recent paper on that also, right? Now about this bilirubin thing, what would you say? Like, what do you think about this distribution of bilirubin, direct and indirect bilirubin? 12 plus 7, 12.2 plus 7.8. It's quite high. I'm sorry, 7.8 plus 4.4, isn't it? Direct more than indirect. So what could be the possible causes?
We have first of all sepsis. That is the main cause.
That you're thinking, yes. And
typically,
underlying
use the bilirubin and OTPT in septic patients. See, now we may have an indirect and direct is almost double. So once such picture is there along with the AKI or renal failure, we don't know. If we have the pre-op investigations, that's good. That you can figure out that it's everything is because of the acute insult. So if direct is and indirect is that gap is there, so how will you narrowed down the differentials in this patient, particularly such patient who has a PPH and AKI developing later on, then can we go with the looking at hemolysis, anything to figure out whether hemolysis is there or not, or there is something more which is causing hemolysis background in the patient, or patient has a high bilirubin, already some insult is ongoing with the liver or the body system metabolics. Can you think of like those things also?
So since the direct bilirubin is higher than the indirect, so
Mostly in
it's
sepsis, it's about 3-4 bilirubin. It's in the range of less than around 5. But if chronic hemolytic anemia there, which although this patient is not fitting into that anyway, then most times patient have a pre-op issues during delivery rather than during pregnancy. It will be picked up, although the antenatal check was not good. So G6PD deficiencies are there where the patient can have these things common. After transfusions, also patient can have high creatinine if something has gone wrong. AKI itself, because of a PPH loss, can be there. But this picture, high bilirubin and then having a OTPT near normal. So ischemia and all those things are less common. It's points out mild like this, but out of proportion. OTPT is less high as compared to the bilirubin has jumped. So we should keep that something is underlying in the patient. That's very important. Maybe tropical fever or something else is patient is carrying on in advance. So PVF is also what you want to see in the peripheral blood film. You said specifically peripheral blood. Is there anything which is related to pregnancy which is can be picked up with this narrow down the differentials?
fragmented RBCs we look for in the peripheral blood film,
Good.
schistocytes.
So schistocytes and all these things are very important to if you are thinking of hemolytic uremic syndrome or TTP or looking at HELP syndrome, all this. Then another investigation very important is the LDH in this patient. We can go with the LDH also, that will figure out what is the heptoglobin level also, so we can figure out whether those things are there or not. So carry on further. Sharmili.
Yeah, I think we have discussed all the possible points in these cases. So I think with as you have seen, the platelets are normal. So HELP is ruled out, right? And I've shown you the trend of investigation in these cases. Patient has actually responded to the conservative management. And this, of course, tells us that probably acute fatty liver pregnancy is not the case. Usually it is fulminant and patient, succumbs to it. That is not the case. Now we have two things like patient, though ANC is irregular and they say blood pressure, whatever recorded was normal, we do not know how much it is reliable, because one thing which strikes is the high uric acid level. And high uric acid level is one of the actually, coexisting signs or the problems existing with severe preeclampsia. So she could be having something of proteinuria, maybe there even before she presented. So we are not sure about that. But nevertheless, she had actually developed secondary sepsis after delivery and with the PPH transfusions and those tamponade, etc., which is now in the predominant scenario. So that could be, there's a small possibility that she might be having severe preeclampsia, because I'm just suspecting because of the high uric acid, because they do not have records. But now the sepsis actually clouds and dominates the overall picture. So we have to treat her in the line of septic shock with multi-organ failure. But what is confounding, is striking is the extent of the liver dysfunctions. Bilirubin of 12.2 is quite high. It doesn't happen, as Dr. Gautam rightly said. Sepsis, you said 2-3 milligram percent will be a little derangement there. It's not that high. But definitely there is some pathophysiology pertaining to the liver itself. So that's the reason we have sent all the things. And this patient obviously improved. Blood cultures came negative. Tropical fever panel was negative. And what we found, and this patient throughout actually never required any respiratory support also. Just after resuscitative efforts of those fluids, antibiotics, oxygen, etc., she improved. And we did not require much of transfusion, etc. So And we are surprised to find that actually she on day 5 or 7, it was a bit late. We found that hepatitis E antibody, IgM antibody, was highly positive. Her titer was very high, right? So it was primarily probably a starting. She had already developed hepatitis E because when we took the history in retrospect about yellowish coloration of the sclera, she had, fortunately, she was at the end of her pregnancy. She delivered the twin. The babies were fine, and but then she developed because of PPH transfusions, tamponade, and she developed septic shock with all this multi-organ failure. So everything, actually, the point message I want to deliver is it may not be one particular condition existing. Because this leads to one complication, this leads to another. They might be having coexisting problems which might be contributing to the complications and the critical state. All we need to do is to follow the basic principles of resuscitations and critical care management, supportive, while at the same time keeping our efforts to find out the underlying predominant pathology which is probably driving the process. This is important treat the cause, underlying cause, also to prognosticate patients. Because somebody, suppose if this patient had lower platelet, like HELP syndrome or acute fatty liver of pregnancy, usually their course is very fulminant and ominous prognosis. Usually, these patients do not survive. But we have seen the other way, like these, that the patients who respond well. And you see, she never went on to require any organ support like NIV or dialysis, etc. AKI improved, liver function improved, her blood pressure was never requiring any support, right? And she was discharged home on day 16. So I would emphasize that, it's just basic things, actually, efforts. We should not falter. We should approach the patient, any patient who comes, ABCD, the principles of resuscitation and our approach should always remain basic. And we should always apply common sense, because if it be it life or clinical science, I always believe common things are common and uncommon things are uncommon. And that was the purpose of I showing the initial slides, that though you say that acute fatty liver of pregnancy is very, very unique to pregnancy, but you see the incidence, it is less than 0.01%. That means 1 in 1,000 patient or probably, or 10,000 patient will probably develop this. So rare things are rare and common things are common, right? Thank you. I think we have covered all the aspects. Then I'll go to this. If we have time, I'll just go to show the second case. Probably it will be a much easier and quickly we go through. Dr. Aarti, you're ready for that? So it's a 20-year-old lady who was 30 weeks pregnancy, and she was also at a village. And her antenatal checkup was also irregular. The husband was in army, and she was with her in-laws at home. 2 weeks before, she was diagnosed to have high blood pressure. So she had eclampsia, preeclampsia, and started on some medication. She had pain abdomen, water leak, and then taken to the due to rupture of membranes and taken to local district hospital. Cesarean section was done for fetal distress. Now, after 8 hours of post-op, she was found to have jaundice, bleeding with PPH, with PAC in situ was provided, and she became drowsy fast. So see, compared to the first case, this patient has deteriorated faster and she has become drowsy. So this is another organ dysfunctions. Now she came referred to our hospital. When she came to us, she was again hypotensive, tachycardia, deep icterus, and low urine output. So what do you think? What is your assessment at this point of time? And
In
yeah, these are the, I'll give you the labs because we do not have time as well, whatever we had, right? So these are the labs: hemoglobin 7.9, TLC 16,000, platelet is 56,000, bilirubin is 6 milligram percent. Now, what is the differential diagnosis?
in the initial part of the pregnancy, in the second trimester, she had preeclampsia, but in now it looked like acute fatty liver of pregnancy. Because there is patient is drowsy, maybe she is in encephalopathy, and there is also derangement in the coagulation profile, and there is there is AKI also, and
sorry, yeah. And what will be the closest differential diagnosis for that?
Closest will be the HELP,
because also you have platelet is low. I have not given you the hemolysis picture, but nevertheless also this fits into that, given a history of preeclampsia diagnosed already before delivery of the baby. So these are the two um, closest diagnoses. And acute fetal liver actually is very highly rapidly fatal. The patient deteriorates very fast, right? And how do you like to manage her when she presents to you?
After whenever we in the ICU, the patient is already intubated, and uh,
So what are
the
the
treatment of
precautions?
the acute fatty
No,
liver
the
of
patient is
pregnancy.
not intubated. We have not intubated her. You would
So,
like to intubate? Yeah.
yes.
Since the
Such
patient is
patients
drowsy,
are
Yes.
just because we had a patient who presented with complete fulminant hepatic failure with the pregnancy. This has been already reported, but we had one patient last month who had a fulminant hepatic failure with pregnancy with INR of 10. So, how will you go ahead with the precautions during such patients, whether it's intubation, ventilator settings, putting the lines? How will you go ahead with such a sick patient who is coming with the uh, drowsiness and other things, keeping even HELP syndrome, we cannot say ruled out because sometimes these patients may press and other things also come with encephalopathy, these patients when they have acute thing. Very not uncommon. So there are three things. One is how you will go with the intubation, how will you go with the ventilator setting, and two, three things because we are short of time. So how we can go ahead the two, three things very quickly in stabilization of this patient.
this patient after receiving in the ICU will patient is drowsy, so we'll intubate the patient. Um, um, we'll take it as a difficult intubation since she was a pregnant female. There is a
Why airway is difficult in a pregnant lady? This is a
first
very
of all,
common questions for all trainees. This is will be definitely asked if you're getting an obstetric case because this is something to do with life and death. So you'll be definitely asked this question if you're having an obstetric case. Yeah, tell us why.
first of all, the weight of the patient that makes the position for intubation difficult.
Wait.
Then weight of the patient, the increased size of the
Huh?
breast. Then the oropharyngeal airway edema is there during pregnancy because of the hormonal changes, and that makes the laryngoscopy difficult. And there also in the physiological there is decrease in the FRC, functional residual capacity, so that gives us the apnea time is less during
Good.
during intubation, before during intubating such patients. So we have to
What happens to
keep
vocal
all
cords?
the yes ma'am.
Vocal cords का क्या? Vocal cords
Vocal cord edema is there.
is also
So
present.
always prefer to use one size less what is for
Yes.
that patients. Mostly even 7 or 6.5 something may be required. Then bruisability is very easy. They try to mucosa is so friable in these patients. Easily they can bleed also during intubation in the multiple attempts. Then once they are very easy that this patient go into during apnea period may go into deoxygenation and this desaturation. So during that part also, and the risk of aspiration is also very high in these patients. So we should take care of all these precautions. Then ventilation, if it's pre-delivery, pregnant patient, if you are going with taking ventilator settings, because these patients sometimes may get during intubation when you are paralyzing, may get spine hypotension also. Although this is the delivered patient, if the patient is not delivered, the risk of spine hypotension without spinal, just with the drugs can happen also. So left lateral position is also very important if required in this patient to maintain the hemodynamics.
So in the ventilatory settings, we'll keep the tidal volume low and rate high. We'll start with the tidal volume of 6 ml per kg and rate around 14 to 16 breaths per minute. A PEEP of 5 and I's to E ratio normal ratio 1:2. Then since these patients they have underlying coagulopathy is there, so we have to we have to be vigilant before putting the central line or arterial line
What do you mean
in this
vigilance?
patient.
What do you mean vigilance? The precautions. If you have to put center line or put the IV line, T line, how will you
In
put?
this, in the center line, we should also always use the right jugular side.
So
IGV we should always prefer.
accessible, easy accessible, expert person, ultrasound uses. So those are, we can go up to safely up to INR APTT of 2.53. That's the international guidelines for interventional radiology. Although we go a little beyond that also in our system, in our hospital, because being a transplant unit, we sometimes can go. There is nothing like a contraindication, but sometimes you may require transfusions also in these patients to be in safe limits.
So, in generally in the sorry,
Yeah, you tell. Yeah, Dr. Arti.
acute fatty liver with the termination of the delivery, the condition resolves. But if the patient deteriorates thereafter, then we have to give the supportive management. We can, if there is AKI, we'll
She
go with
has
the
already
dialysis.
delivered. No, she has been delivered outside.
This is delivered now.
Yes.
So I twisted the question if she comes prior to delivery.
Acha, okay, right, okay.
Just for the delegates.
Then we can go with the plasma pheresis also. That is one option in such cases, and liver transplant.
Because you are a liver transplant unit, Dr. Gautam will rapidly provide that. But most of the
Transplant
centers,
indications are very different.
very different,
Most
yeah.
of the patient in pregnancy, once which are related to pregnancy, after delivery, they come out most of the times because it's caused by transplant as such is not an option often because the results are not good. These patients get post-transplant sepsis very common. So transplant is only for the patients who are not recovering. Otherwise, that too after 4 or 5 days we see, but by 24, 48 hours, most of the patient will normalize once the insult of the pregnancy is taken away. Because that's whether it's even if the we require mostly supportive treatment is good enough in these patients. Transplant, yes, sometimes is required if the patient is having underlying coexisting previous disease may become an indication. But most of the times, patient will recover after delivery of baby, whether it is a HELP syndrome or it's a acute fatty liver of pregnancy. Supportive care is very important because these patients sometimes die of cerebral edema during ALF, acute liver failure. So management is very meticulous, targeting cerebral perfusion pressures, not giving an insult to the raised ICP already. So those things are important. Going with the plex and especially when one has put that TAMA, actually I would say thrombo microangiopathies, these patients. So plex and those things may be helpful in this patient.
Right. And just, little deviating from this particular case, when they go on to ventilation and they actually might develop secondary ARDS for a variety of causes, like all they have risk factors for developing secondary ARDS. So you might be also asked, not in the exact case, but in a patient who is pregnant, probably developing pneumonia and ARDS. So prone positioning, those are what are the challenges. I'm just saying for the sake of exams, lateral extrapolations of the possibilities. Like they might also ask you about pruning in a pregnant patient. It is not completely contraindicated. It's a relative thing, but you have to make sure that there is no compression of the AVC or the tummy is not compressed. You have to take more of those precautions than not. And we have actually pruned quite a few patients during COVID-19 pandemic as well. And again, dialysis, the timing of dialysis in a patient who develops brachy. Brachy is a very distinct entity and is being more commonly, discussed in different forums now. So indications of dialysis in cases, it is not different. It is the same one which we normally follow in conventional other AKI cases as well. So concluding this case, actually she had rapid progression of organ failure despite all organ supports provided, and she succumbed. The differential diagnosis, of course, remains closest at these two, acute fatty liver or pregnancy and HELP in her case. Right. So anything you want to ask, Dr. Arti? Right. If not, then HELP syndrome, actually, it's a life-threatening condition. Remember, as is acute fatty liver or pregnancy, 80% cases, there is history of preeclampsia, there is microangiopathic hemolysis, as Dr. Gautam was mentioning. Blood cells, you see, this might come as MCQs, or sometimes, they just give you a film and ask you to interpret. And if you go for liver pathology, histopathology examination in such cases, in severe preeclampsia, which is usually associated with HELP, there is fibrin depositions, there are liver cell necrosis. So hepatocellular damage occurs in such cases. As opposed to acute fatty liver or pregnancy, you see, these patients, usually there is a genetic defect. There is a deficiency of one particular type of enzyme. It is also comes as an MCQ. As the most common genotype associated is the this mutation of this enzyme, that is long chain 3-hydroxyacyl CoA dehydrogenase deficiency. And usually the mother may be heterogeneous, and then the fetus is homogeneous. What happens during later third trimester of pregnancy, there is increased production of the fatty acids, and the metabolism rate both of the fetus and the mother starts increasing, and then the mother is not able to handle this triglycerides of the long chain fatty acids, and this leads to rapid affection of the hepatocellular cells and rapid decline in the liver functions, leading to acute liver failure. Usually it is associated with multiple gestations, and that could be concomitant presence of preeclampsia or HELP syndrome in these cases. And male fetal fetuses are more usually commonly involved than not. And this patient, as I said, was actually did not do well. So challenges in such cases are usually, again, the severe ones like deranged coagulation, transfusions. And as Dr. Gautam was saying, if they present pre-delivery into a unit, delivery for such patients is also a challenge because anesthetic challenges are there. Usually, obviously, they cannot be given regional anesthesia, and you have to go for general anesthesia with out of risk, for high risk, and airway is an issue. You have to be ready for multiple transfusion products. Apart from this red cells and the plasmas and the platelets, also I would like to mention about this availability of factor complexes. Now, either prothrombin factor complexes at the 3-factor or 4-factor complexes are available. They contain factor 2, 5, 7, and 9, and also contain the 4-factor precesses especially, and also contain some extent of this protein C and protein S. So remember, these options are also available in a patient who is frankly bleeding, because a lot of transfusions actually also in some stage or later leads to TRALI, transfusion-related acute lung injury. It's also a very common phenomenon that we see in such patients after massive transfusions. And of course, multi-organ dysfunctions independently is possible, whatever organ you name about it. So termination of pregnancy in such cases is a definitive measure, along with the continued supportive measures. Acute, if you go for the histopathological examination of the liver, you find flat globule deposition in the centrilobular hepatocytes. It sometimes comes as an MCQ. So how to prepare for delivery? You have to deliver the fetus, and multidisciplinary team care is a must. So you have to alert the obstetric team and the neonatal team as soon as the patient arrives to a center. If you are at a lower center, refer to a higher center. Of course, you have to make sure that the patient is having at least some oxygen during transfer. If possible, intubate such patients and get good IV lines, some fluids, and start some vasopressors as required, and shift to a higher center. Hydration, nutrition, and check for fetal growth quickly. The ultrasound will be an answer for that. If your fetus is close to maturity and is not close to maturity, of course, steroids can be given. And be vigilant for possible maternal complications, because usually maternal complications, if the delivery time is delayed, becomes higher. And we talked about arranging the blood products, organ support therapy as necessary, and neonatal IC facility is a must. So key points, again, I would emphasize on the clinical history taking and the clinical examinations. Think about all the possible causes, both the pregnancy specific and pregnancy non-specific, or the routine causes which can happen to any patient from the community. We need to exclude sepsis and tropical fever, especially in the Indian subcontinent. Serum uric acid is actually an LDH. They are very unique tests, especially in a pregnant lady, which can point to existence of preeclampsia, and usually the atypical manners. And do not forget about this hepatitis causes, especially again among Indian populations. Ultrasound is very helpful, not only as a focus for patients who are in an unstable patient, also for other causes, like most importantly, quickly about the written products of conceptions, and also other pathologies like cholestasis or biliary stones, etc. And urine dipstick for protein actually has to be also done in such patients, if not done previously, because proteinuria in urine in a patient who has not been hypertensive before, of course, points towards a possibility of preeclampsia, which can worsen later. Thank you very much. And I'll stop sharing with that. You would like to ask any questions, Dr. Aarti?
Ma'am,
Right,
I have just one question.
Okay.
Yes.
Ma'am, which antibiotic will you prefer for a suspected case of puerperal sepsis, ma'am? Is there
Yeah,
any
hmm?
guideline? Sepsis, puerperal sepsis, which antibiotic will you prefer, ma'am?
Right. Actually, as we discussed this case, actually, first one, it depends on what organisms are you trying to cover. Second, it depends on the patient factors like patient profile. If what comorbid conditions patient has got, what are the risk factors for either getting or not getting multi-drug resistant organisms. As you saw the first case, she comes from community. She didn't receive any antibiotics. She was never sick before her delivery. And then she had a section, probably she just received prophylactic antibiotics, and then she had PPH, tamponade, etc. given. When she came to us, clinically she was in septic shock. So it would make sense to give her a broad spectrum antibiotic, which I would target to cover this anaerobes and the common gram negative ones, this E. coli, or the gram positive ones like group of hemolytic streptococci, staph aureus. All this together can be covered by this piperacillin tazobactam and along with metrogyl, because it has got more sidal effect on this anaerobic group of organisms. And surgeons are usually fond of metrogyl. So that is a good combination. Suppose a patient who has been having, hospitalized, suppose she had a hospitalization for whatever cause. Now she has been in a hospital for a long time and she has received multiple antibiotics. She is coming now to a higher center like yours, and she has persistent septic shock. If you suspect now this because she qualifies for now getting coverage for MDR organisms, then you obviously would escalate to carbapenems for that matter. And depending if she has diabetes, she has kidney impairment or not, if she has been receiving parenteral nutrition, etc., you would also think about the fungal. But to start with this piperacillin tazobactam, or if you say ceftazidime, that is what do you call that? I can't. Ticarcillin or clavulanic acid combination. These are also good enough for patients who are directly coming from the community, along with some anaerobic cover. Like clindamycin also you can use. Actually, some patients who have got pupil sepsis, they might develop just, shock, non-refractory shock. There are sometimes syndrome called SSS, that is staphylococcal shock syndrome. And you can actually use clindamycin in those cases, because clindamycin, unlike metronidazole, also has got sporicidal effect. It is said that but it's a very rare phenomenon. But if you are suspecting, you can very well give clindamycin in those cases instead of metronidazole. I hope it answers your questions.
Yeah, yes, ma'am. Yes, ma'am. Ma'am, one more question to Dr. Gautam, sir. Sir, you have explained about the ALF with INR of 10. So, should we transfuse FFP as a prophylaxis before taking central or something?
Yes. For delivery, we have to normalize the coagulation profile. If you have a thromboelastography in such patients, that is very helpful, because that gives the functional status of the coagulation profile. Like we had this patient last month, where we had this patient having 10 INR and pre-delivery. So we prepared that patient within 6 hours of coming to the hospital, because she was comatose with encephalopathy, fulminant hepatic failure. And those patients need, I would say, higher centers where the transplant facility is available, because they are used to handle such patients, correcting coagulopathy very quickly. Another thing I want to see, if there is any patient with HELP syndrome or anything like pregnancy related, if there is a right hypochondric pain, always think of subcapsular hematoma things, because these are patient very high risk of, while you're handling it, even during palpation or your labor pains, when you are pushing the patient, may have a rupture of liver, which is almost fatal. I have seen one patient, although we could resuscitate that patient, during she had a hyperkalemia because of combination of HELP, and during she had arrested during CPR, the hematoma ruptured actually. Although we could rescue that patient, she survived luckily, but it's very difficult to make them survive if the patient has a ruptured liver because of hematoma. But I think overall, these are rare situations. Common is HELP coming with maybe press, or maybe having convulsions and other things, we should be very much prepared to handle convulsions, because that can happen. 50% patient may come either on side, peripartum, even cardiopathy may be sometimes happening later on after delivery. So those things, don't take that patient has no normal blood pressure. Can happen, even patient can have without proteinuria also help. That's now coming up, that odd findings are there. So we should keep common things, although common, but approach remains the same. Whether patient is having any patient having convulsions, how to go ahead with the convulsions, controlling, preventing hypoxia to mother and the fetus, that is there, and then going ahead with the delivery prompt. That's always that should be the common things. So the approach remains the same principles.
Yeah, one point also about the platelet limits for conducting a cesarean section. It is also often asked. What is the limit for Dr. Ang? Should you like to answer?
50. So
How much platelet should be there before? I mean, obstetrician would like to take patient for cesarean.
50,000.
Somebody
50,000.
written 50,000. Someone has written 80,000, but 80,000 is usually for the neurosurgical cases. For obstetricians, if you have to, they are in help or whatever cause they are in DIC or maybe acute fatty liver or pregnancy. If it is more than 50,000, with further backup, you can take the patient for delivery of the fetus. Because because the cause is patient is the fetus and the placental circulation and the fetus. Once it is delivered, there is usually mother reverses very rapidly. So you have to take the patient under high risk, of course. More than 50,000 is you can take, right?
So this is another.
And for
Yes, go ahead, please. Go ahead, please, Sharmili.
yeah, and INR, how much you follow? INR, INR देखते हैं?
1.4.
1.4 to 1.5, yeah. And we have to, of course, you need, backup of blood products. There is no doubt about it. But these are the thresholds and also often asked in exams, right? Okay.
Okay, so I was just highlighting why the platelets, even if it is 20,000, 30,000, these patients not did easily. The reason is most of the times they are young platelets in these patients. It's a more of a destructive pathology in the platelets, which is causing that. Just like not exactly the ITP, but it's not a bone marrow suppression where the things are different. Here the platelets are active and they work very well because they are in the history. People have given spinal anesthesia with 400 platelets. Accidentally, they came to know later on that the platelets were 400. Patient didn't have problem. So in pregnancy, that is the beauty, especially in the health center, because it's a more of destructive pathology, which is leading to whether it's a MHA or other things. Platelets are actually whatsoever the platelets are available, they are very active.
Right. And in the post-operative period, like suppose still there is persistent deranged liver functions, few of the newer therapies, which is not very much common into practice yet, about this extracorporeal removal of these toxins like this bilirubin. We have the specified filters are being available, which are being increasingly used. I have only experience with one patient, but I come to know, I mean, if they ask you about new therapies, they are not very common use, clinically used now, but they are being marketed and available for cases if you wish to try your patient on those. I think we have discussed and it was an extensive discussions. And thank you, Dr. Aarti, for taking up this case discussion with a short notice. And so much, thanks so much to Dr. Gautam as well. And thanks to the team for the Academy, Dr. Asif, and all the participants. I hope it was educative.
Thank you, sir. Thank you for conducting a very good class. I hope every student will get benefited in their real exam. So thank you, sir. Says for few word to how our DRNB or DM student will prepare for final exam.
So the thing is, common things are common. So what we want to know in exam is most times, I tell all my examiners also, when we go with the DNB and DM also, that ICU, when we are looking after, it's how do you stabilize the patient, common things, because there is a multidisciplinary approach. So our approach is like, if we are intubating the patient, what are the precautions you are going to take? If we are handling how to, in ICU, the intubation is going to be difficult. many of the patients, if they are developing some complication, multiple organ failure, what is the sepsis definition? Like alone TLC may not go up. So we try to find out what are the sepsis definitions, what are the sepsis guidelines. We go always, sepsis guideline should be on the tips. That's very important. So those things, then coming out with the AKI criteria, when to like antibiotics, chronic, we cannot go with the Cox formula, which is there for CKD. So there may be augmented clearance also. So we have to be, there should be the general common problems like tropical fever. So those things are always asked in the exam, and one should be familiar with those things.
Thank you, sir.
And fluid
Sharmili,
those things also. The examiner is very fond of dynamics assessment, fluid in the ICU, even ultrasound, B lines, and these things. I mean, whatsoever we are doing commonly in ICU, person should know also in ICU. I mean, who's appearing for the DM or DNV program.
thank you, sir. Thank you. Sharmili, for your take home for the student.
I think we have had an extensive discussions. I would say obstetric cases, if it is there in a unit and if it is there in one of those bunches for your OS case, be it EDIC or be it IDCCM or any of the exams, it would be definitely asked because it is a very favorite question or case scenario for the examiners, and it's highly mark scoring as well. Because see, these are only 6 to 7 case conditions are there which can cause or lead to emergencies in a pregnant lady. So of this preeclampsia, hemorrhage, eclampsia, convulsion, like this patient for liver failure, you develop multi-organ failure, or you have now brachy these days is also added. So we have adequately emphasized during the case discussions. And all management supportive aspects are more or less similar to usual critically ill patients. But of course, there are some pregnancy specific points. And physiological changes in pregnancy, one should be very thorough because once you think that if you're not doing well in the critical care aspect of the patient, they'll certainly ask you about this physiological changes because these will be interrelated, right? Another thing I'd like to emphasize is about, most of our trainees or the young doctors are now very much enthusiastic about POCUS. Any patient comes like this first case, as I said, she had a history of PPH, she comes with a tamponade, she is hypovolemic and she is hypotensive and tachycardic. First thing comes to mind is hypovolemia, unless otherwise proven. So you cannot say I'll do a POCUS and then I'll decide about the fluid. Likewise, and in a patient who is tachypneic, who is on spontaneous breathing, POCUS is not going to be very informative, right? With a heart rate of 120, 125, how much cardiac contractility also you can see. So POCUS is not something, you should be holding first before you start doing anything. You can give oxygen and give a small aliquots of fluid. Be pragmatic and practical. This sounds good that you know about POCUS. So these common things, if you say, you'll never falter and you'll definitely pass. And then you go on to score higher marks. But if you falter in common things, then they would say, no, she's just, he or she is beating around the bush and probably, once your first impression is spoiled, it becomes very difficult to make up later on. But never mind. I think, as I said or insisted, common things are common and uncommon things are uncommon. Whatever we do, generally, just say those things and then proceed. And do not lead to questions. Because if you say something, I'll go for liver transplant in a patient who has got liver failure, then you're asking for trouble.
Absolutely, absolutely.
Then the examiner asks you, उसमें तो time चला जाएगा, so you'll be saved.
Absolutely. And regarding this obstetric emergency, I want to add those who are preparing for the EDIC and planning for EDIC part 1 or part 2. Even part 1, there is you will get at least 2-3 questions from the obstetric emergency. And last few years, the trend is like Didi, we are taking interview of student who has just given the exam or passed the exam. So every year there is a one obstetric case they are giving. So last time they have given acute acute hepatitis E actually in a pregnant lady, and this year they have given health syndrome. So they might get long case on the, and from that they come to the coagulopathy, cesarean section, after that post PPH management is like that. So it's a very important topic, and you have covered nicely. Thank you. Thank you, ma'am.
Thank you. Pleasure,
Thank you,
pleasure,
sir.
Dr. Asif. Thanks once again, the team working behind the scene, and all the participants. Very best wishes for your performance. Thank you.